Hello and welcome. I'm Dr. Louis Hassel coming to you from the campus of the University of Oklahoma Health Sciences Center. And our program is a part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association. I'm very pleased today to share a case that is not so much a diagnostic challenge, but just a fairly common entity that is encountered, but yet not often emphasized in surgical pathology training. Our patient is a 45-year-old woman, and she's had this recurrent swelling on her dorsal aspect of her wrist. And she's come to medical attention to sort of seek some relief. It's not particularly painful, but seems to come and go at times, and just creates a little bit of disfigurement in her wrist. So for cosmetic as well as other physical reasons, she's interested in seeing what can be done about it. Well, first of all, let's just consider from a clinical standpoint what some of the causes for swelling around a joint might be. First of all, joint effusions, any sort of excess fluid into the joint cavity can certainly swell a joint. Sometimes those are due to infection, although soft tissue infection could also create a joint or periarticular swelling as well. Common disorder, the ganglion or synovial cysts that can occur around joint spaces involving tenosynovial tissues and so forth can also cause that, as can the sort of benign tenosynovial tumor, the giant cell tumor of tendon sheath, which we've talked about in previous episodes. Trauma, hematoma, fracture, those also can lead to joint swelling, but those are usually not a diagnostic problem. And then finally, there are some neoplasms, both nerve sheath and other soft tissue neoplasms that can be considered in this type of a scenario. And again, would usually not be associated with pain. So here's a clinical image of what this looked like, and you can see kind of the irregular nature of it. It's here right along the dorsal aspect of the wrist and has some variability to it. So she opted to have a surgical resection, although other kind of treatment options are available, which can include just kind of watching it or potentially draining it to see if draining or aspirating the fluid out will cause it to spontaneously regress, which occasionally happens. As we look down here, we see a variety of kind of cystic open spaces surrounded by fairly dense collagenous tissue with a little bit of basophilia and so forth to the wall. Not any atypia here in the stromal tissues. And not much of a lining around any of these spaces. Here you see maybe a little suggestion of a sort of a spindled out area, a little bit of red cells in the lumen and so forth, but nothing that looks particularly worrisome or might be construed as neoplastic. You may occasionally see vessels and a few inflammatory cells in the wall of this lesion, but certainly looks consistent with a tenosynovial type cyst or a ganglion cyst in this patient. So what are ganglion cysts? Well, these are essentially what we've just seen, a sort of a bland cystic space, sometimes multilocular, that's filled with a very viscous hyaluronic rich fluid. They tend to be located along tendon sheaths or adjacent to a joint, but they don't have any joint connection per se. Most commonly, these are seen at the wrist and most commonly in the dorsal aspect of the wrist as seen in this patient, but there are many other possible locations, usually in the extremities, hands and feet, but sometimes in larger joints, knee, and so forth. Interestingly, women seem to suffer this more frequently than men, but the age range is pretty broad. From pediatric to mid to late adulthood even can be the point at which they present. The size may wax and wane, but it's usually painless unless it's interfering with joint movement or compressing a nerve or something of that sort. A variety of etiologies have been postulated, everything from sort of congenital developmental problems to trauma to various other sorts of things, but no single unifying etiology has been identified. And as we've indicated, the very viscous fluid is usually clear and can be therapeutic at times, but they may recur after aspiration. We've reviewed the histology. I thought maybe we just look at a couple of other locations to see a little bit more of the kind of perspective or spectrum of disease. Here you see one with a few smaller cysts, and as you see around many of these cysts, there is also this myxoid change. So this can become quite prominent depending on trauma to the cyst or other sorts of changes, so that it can appear at times like a primary myxoid neoplasm or myxoid process that may cross into a differential diagnosis with other entities. Here's another case in a pediatric patient. And this one, as you can see, associated with quite a bit of osseous differentiation or bone formation in the wall. This may be either primarily intraosseous, occasionally those are seen, again, near a joint space, or it may be a secondary metaplastic phenomenon that's occurring in this type of a situation. But the key, of course, here is recognizing the bland cystic spaces, bland fibrocollagenous tissue, the tenosynovial type lining tissue, and allows you to make that diagnosis. So I'll provide a link to these slides in the description, and you can take a look at them at your leisure as you'd like to study them further. So differential diagnosis we've mentioned includes myxomatous lesions, both juxtaarticular myxoma as well as more conventional myxomas, although intramuscular myxoma is usually deep in the large muscles, but juxtaarticular myxoma could cross the differential with this. Sarcoma, low-grade myxofibrosarcoma. This is a relatively uncommon and has at least some nuclear atypia, plus it's usually much older patients. And then neural lesions, neurofibromas can have myxoid changes, usually do not have the cystic spaces that we've seen with this. So our final diagnosis today is a synovial or ganglion cyst, and that should be your diagnosis when you encounter your next case, because these are fairly common and undoubtedly will cross your eyes. Well, thanks you so much for joining me. I hope you enjoyed that little brief run through with a fairly common entity and a good review of kind of the differential diagnosis we encounter with these kinds of lesions. So I hope that'll be helpful, and until next time, thanks so much for joining me.